So continuing the excellent work from the Cancer Care Services team, we've got Midori. Now Midori is unwell, but is at home and is going to be presenting from home. Midori has been the BMT pharmacist at the Royal Brisbane and Women's Hospital for a long time. I don't know how long, but it's a long time. She completed a Bachelor of Pharmacy in Japan, a Masters of Oncology in the UK, and is in the final year of her PhD at UQ. Her topic is oral mucositis in BMT patients. Her areas of interest are in supportive care in cancer patients, health service research and drug uses in bone marrow transplantation. She has a number of publications around these areas and has presented in many national and international conferences. Take it away, Midori.
Thank you for your kind introduction. Unfortunately, I can't be there today because I've picked up COVID somewhere. So my topic is oral mucositis infection and microbiome, but infection and microbiome is not yet really my area. So that's why it's a little bit smaller font. So my presentation includes a part of my PhD work and the current trends and the interest in oral mucositis research. So I will start with the introduction of oral mucositis and then randomized trial I conducted. Oral mucositis is very common toxicity of high-dose chemo or radiation given before transplant, bone marrow transplant. It's also common in head and neck cancer patients receiving radiotherapy. Transplant patients with oral mucositis have an increased risk of infection, and one study even reported lower survival. Despite the clear negative impact, very few interventions are currently available. MASC published evidence-based international guidelines for the prevention and treatment of oral mucositis. They have various study groups, including the mucositis study group with 400 to 500 members. For bone marrow transplant patients, the only recommended preventions are oral care, cryotherapy with melphalan, which is a sucking ice, photobiomodulation, which is laser therapy, and polyphenol in the limited patients cohort. More interventions are available in head and neck cancer patients, including benzidamine, different mouthwash, honey, and glutamine. These non-steroidal anti-inflammatories and the natural honey are not appropriate in transplant patients due to safety issues, particularly whilst oral glutamine is recommended. IV glutamine was shown to increase mortality in transplant patients in one study. Now, this polapril zinc is a chelated compound of zinc and L-carnosine, which is an amino acid. It's licensed for the treatment of peptic ulcer disease in Japan, Korea, and India. In Australia, it's used and approved as a zinc supplement. Preclinical data suggest the anti-inflammatory and antioxidant properties of this compound. And in animal models, it appears that the polapril zinc adhere directly to the ulcer site. From my entire literature review, it was the only possible effective prevention of oral mucositis and likely to be safe intervention in transplant patients. Polapril zinc has been studied for the prevention of oral mucositis. Several studies. There have been 3 RCTs and more than 10 retrospective studies. Majority of studies demonstrated the effectiveness of polapril zinc, but there are some study quality issues. These issues include small sample sizes, retrospective studies where test arm and control arm were treated at a different time point. And also the use of inappropriate statistic tests. None of the studies controlled confounding factors such as treatment regimen, and none of them mentioned details of oral mucositis assessment. So this problem is not only polarizing study, it's generally the problem in all oral mucositis studies. So in all polarizing studies, mouthwash or lozenges were topically used, but they were ingested after topical use. So polarizing needed to be evaluated in a reasonably good quality prospective study, preferably outside of Japan, because basically all studies were conducted in Japan. So this TOPAZ study was a single center phase 2 open label RCT. Inclusion criteria was adult patients who received moderate to high risk regimens to develop oral mucositis. Sample size of 108 was calculated based on the past papers. Randomization was stratified by conditioning regimens. Patients the study arm received normal saline mouthwash and polarizing mouthwash QID. Patients who allocated to the control arm received normal saline mouthwash, then sodium bicarbonate mouthwash QID. Mouthwashes were not swallowed after use. The primary endpoint was the incidence of grade 3 to 4 oral mucositis, which is a severe oral mucositis. Secondary endpoints included the duration of grade 3 to 4, grade 2 to 4 PCA use, nutrition supplement use, and patients' reported outcomes. So the study outcomes were measured by the WHO oral mucositis scale by the nurses. This scale is the most frequently used oral mucositis scale. And basically, pain is grade 1, ulcers are grade 2 to 4, depending on what the patients can eat. Nurses went through a specific training to accurately grade oral mucositis. Patients' reported outcomes were also used. They reported mouth and throat pain separately, and functional limitations every day. So this is the patient's flow chart. So in total, 108 patients were randomized. Control arm 53 and polarizing arm 55. And they are all included in oral mucositis analysis. And 45 patients in the control arm and 46 patients in polarizing arm completed self-assessment. So they are included in patients' reported outcome analysis. These are the results. Quite disappointingly, the incidence of grade 3 to 4 oral mucositis was exactly the same between the arm and the secondary endpoint duration of oral grade 3 to 4 oral mucositis, incidence and the duration of grade 2 to 4 mucositis, PCA use, nutrition supplements. They are non-significantly worse in polarizing arm. Patient self-assessment was completed by majority of patients, similar to the nursing assessment. Patients reported greater pain and limitation in the activities in polarizing arm, but they were not statistically significant. Interestingly, in both arms, patients reported significantly greater throat pain compared to mouth pain. So from these results, topical polarizing didn't work. So this paper is just forgetting about polarizing. We compared febrile neutropenia and bloodstream infection between patients with or without severe oral mucositis. Due to small sample sizes, there were only trends of more febrile neutropenia and bloodstream infection in patients with severe oral mucositis. Significantly longer neutropenia, so it may be a bigger contributor than mucositis. Now, I will briefly introduce currently growing interests in mucositis study. It's oral and gut microbiome as a target for the management of oral mucositis. So it was well known that oral bacterial load increases in oral mucositis, and it's correlated with the severity of oral mucositis. And the studies showed that germ-free mice and antibiotic-treated rats had less oral mucositis. This knowledge easily led to the hypothesis of oral bacteria cause oral mucositis that is leading to systemic infection. As a result, many clinical trials tested antimicrobial mouthwashes or lozenges, and they failed to show the benefits. It's interesting though, only macrolides have positive data. But now, generally discourages trials for the prevention or treatment of oral mucositis. In our clinical practice, we give many antimicrobials to transplant patients, including antiviral azoles, ciprofloxacin, and peptides or vancomycin, and they still have oral mucositis. So it's very, very difficult to understand why germ-free mice has a less mucositis, but anti-infectives still do not work. It was found that both gut and oral microbiome lose their diversity, and it's shifted in oral or gut microbiome, oral or gut mucositis. Collaborative team of researchers in Adelaide, Netherlands, and Brazil proposed hypothesis based on the currently available gut microbiome and possibly oral microbiome contribute oral mucositis via systemic immune responses, and gut and oral microbiome interact each other by bacterial translocation. It was published by the same group. More specifically, there is a shift from commensal bacteria to pathogenic bacteria in oral mucositis. Commensal bacteria regulates pH of mouth and create antimicrobial peptides. In oral mucositis, these are lost, and instead pathogenic bacteria produces various ligands that stimulate toll-like receptors and the downstream pro-inflammatory cytokines. So this TOPAD study, it was a negative study, but will be presented in MASC meeting in Japan this month, and the paper is under review. I'm a member of a MASC mucositis study group, and hopefully there will be lots of discussion around oral microbiome and mucositis assessment. As a conclusion, so topical chlorpyrifos zinc had no effect in prevention of oral mucositis. There might be some effect when it was used systemically, because I realized chlorpyrifos zinc is not soluble in the mouth, but soluble in the stomach in acidic conditions. So it may work differently in the stomach. So mucositis assessment methods needs to be reviewed. As throat mucositis was revealed as a main issue in transplant patients. So the use of WHO scale, which relies on oral ulcer, may not be appropriate. Or even we might just need to assess upper GI gastrointestinal mucositis, not really saying oral mucositis. So challenges in oral mucositis study in transplant patients include safety concerns in highly immunosuppressed patients. And it may be more appropriate to consider oral mucositis as part of systemic inflammatory response. And in the future, oral or potentially gut microbiome and associated inflammatory response may be the target to manage oral mucositis. I thank my PhD supervisor team and the patients who participated in the TOPAZ study, and the doctors and nurses on 5C, my pharmacy colleagues, and the other colleagues from cancer care. And finally, RBWH Foundation for financial support through the scholarship. Thank you.
Okay, thanks so much, Midori. That was great. Thank you for being able to present from home even when you're sick. I'd like to open the presentation to questions from the floor. Adam.
Thank you, Midori. It's Adam Stewart here. That was
Hi.
a wonderful presentation. I was just asking about sort of mucositis prevention and what your thoughts are about sort of, sucking on ice and those sort of things. And is that something that's routinely done in your unit or recommended?
Yes, sucking the ice is very simple ways to prevent mucositis caused by malpharynx only. The theory is just make your mouth very cold and the small vessels in the mouth shrink, and then less malpharynx goes into the mouth. Malpharynx has the very short half-life. I think that was 1 hour or something like that. So 2 hours of sucking ice makes quite big difference. And this is probably the most evidence-based prevention. And we routinely use it in our unit.
Excellent. Thank you, Midori. That's great. Thank you so much, Midori. That was a great talk.
Thank you.